Okay, we'll get started. So welcome everybody to our second lecture of the series. This series is all about how to survive your first set of surgical on-calls. Today with us we have Ben, who's an F2 doctor that I've had the pleasure of working with. He's had great experience doing surgical jobs both in his FY1 year and also now in his FY2. So without further ado, I'll hand over to Ben.
Well, thank you, Jen. So hi everyone, like Jen said, I'm Ben and I'm just going to be taking you through a few common scenarios on the ward that you'll be faced with as F1 doctors on surgical jobs. So we'll be going through in this lecture abdominal pain, vomiting and urine output. So that's obviously quite a few topics to get through. So I've kind of split the lecture up into three with a case for each of those. I'm going to try and make it a bit interactive if possible, just so it's not me talking at you for 40 minutes or so. So to do that, if you all sort of have the chat box ready with just reply to all, and there's a few interactive slides that we'll try and get you involved in if we can. So a bit about me. So I started as a doctor in Leeds last year, and I did a general and acute medicine job first, and then moved on to trauma and orthopedics. The plan then was for a nice 4 months of community psychiatry with no weekends. More on that later. I then moved to Harrogate and joined Gen for peds and neonates, haematology and oncology, and general surgery last, which is what I'm on at the moment. So coronavirus changed my plans slightly. So if anyone is at Leeds Med School, they've probably heard the rumours about trauma and orthopedics at the LGI. Essentially, it's just quite a difficult job. The rumours are true. So I had 8 months of that. And then my haematology oncology job, which is actually something that I'm interested in, got turned into general COVID wave 2 cover on a ward that covered stroke, neurology, general medicine and elderly medicine. So that was quite an interesting experience. So, like I said, I'm hoping to give you a structured approach to answer common surgical bleeps that you'll get on the ward. And we'll go through pain, vomiting, and urine output. I just want to sort of go through how I would go about assessing and making a differential diagnosis for these three common presenting complaints, what sort of investigations you'd be expected to get started with as an F1, and what management to do as well. So you're already all doing better than me. I kind of wish I'd joined something similar when I was in final year, just to get a bit of a first-hand experience on surgical jobs at an F1 level. So let's get going. So our first scenario is abdominal pain. So we've got a 59-year-old male and the nurse is phoning you to say that this patient is complaining of abdominal pain for the last few hours. Can you come and see them, please? So this is first attempts at interactive. So if you'd like to open up the chat box, I know you had a meeting recently on bleeps. Can you try and have a think about what you might need to find out down the phone about this patient with abdominal pain? And I'll just get the chat open. Brilliant. So OBS. Yes, the first three answers. That's probably one of the most useful things to get down the phone because you will be able to help prioritize your patient from the get-go. Presenting complaint and why they're in hospital, background assessment, news score. That's brilliant. Someone's starting to think about their SBAR. How severe is the pain in any recent surgery? And the last time they opened their bowels and are they passing flatus? So that's all really, really good stuff. So to think about that in a structured way, if possible, it's really great to try and ask the nurses, and it can sometimes feel a bit rude, but if you do it politely, they don't mind. Ask for an SBAR. All the nurses should know what that is. And if you don't feel confident just asking for an SBAR handover, trying to sort of take that information out from the nurse bit by bit. So like you've said, what they've come into hospital with, what their working diagnosis is at the moment, and what treatment and surgery they've had so far. And don't forget the logistics, their name and their hospital number. Then you've got to try and prioritize where on your list of people that you've got to review that you're going to go see that patient. So ask the nurse, are you worried? Does this patient look unwell? What's their news score and what's their pain score at the moment? And then I've just put that red flag in the corner to start thinking about worrying causes of abdominal pain that would mean that you have to get to that patient before other patients. So for surgical patients, that's bowels not opening, vomiting, tender abdomen, or fever would be symptoms that would get me to that patient before another. And then a few more just logistics. Who's calling? So who do you go and find when you arrive to the ward? Where are you calling from? Where are you going to go? And sometimes you will just ask yourself, why are you phoning me? It will be 3 a.m. on a Sunday, and they'll be phoning about a patient that's had abdominal pain for 3 weeks. And you ask them what their pain score is, and they say it's 4. And you ask them what their pain score normally is, and they say 4. And you ask them whether they've given their PRN analgesia, and they say no. So some of these cases you will be able to sort of triage and just give verbal advice over the phone, safety net, and ask them to phone back if things change. And then the last thing before you hang up, just think in your head, is there anything this nurse can start doing for me to make my life easier when I get there? Can they organize an ECG? Do I want them to do a urine dip? Do I want them to repeat the observation so I've got a repeat set ready when I arrive? So you've asked all those important questions down the phone. However you organize your list, you'll find the best way for you. You've got I have little squares on mine for each patient, and you've got their name, hospital number, what the nurse wants you to do, and you're walking on your way to the ward. So this is what I call the walk thoughts. And it's just a process of sort of going through in your head, almost running through what you're going to do before you get there. And this is really, really helpful, especially for slightly more urgent situations. If you have an idea in your head of when you get there, what you're going to do, are you going to go to see the patient first, or do you think that you have time to look at the notes? If you do have time to look at the notes, you'll get a bit more of a handover that you may not have got from over the phone, because nurses don't always know all the answers to your questions, but they can start finding them out. Have they had this pain since they came in, or is this new? Is there anything else going on? Have they had a surgery? Do I need to be worried about an infection? Has the nurse told me that they've got a fever? And just start thinking through what sort of investigations you might need and whether you'll need to discuss that with anyone. And then it's not cheating. You'll find your own apps that work for you. But I've got a couple of apps on my phone that I really find useful. One of which is Pocket Doctor. And that breaks down a few common presenting emergencies, such as a GI bleed, chest pain, and it breaks down all the observations. So low SATs, fast heart rate, and it just gives you a sort of checklist of things that you should probably be doing at your level. So that can be good to look at if you think that you need some prompts. iRecess is brilliant as well for ALS algorithms and bradycardia and all that things. And obviously Dr. Google. So what I tend to do when I get to a ward, if I've been called to see someone out of hours, first thing I'll do is get onto the ward, introduce myself to the nurse who's phoned, and just go and look at the patient. That can just be really quick, assess them, say hi, I'm Ben, I'm the doctor who's come to see you. I'm just going to go get your notes and have a look through everything and come back. If they can talk back to you and say, that's fine, doctor, then you've probably got time to go and do that. If they're unresponsive or they're sat there on 15 litres of oxygen, you've probably not got time to go back and look at the notes. So if they are okay, find the nurse, find the notes, and just go through and get any bits of information that you've missed from the verbal handover. So especially important in surgery is what surgery they've had and how many days post-op they are, because that changes what you might think in your differentials. If someone's unwell, you want to make sure that you check the front of the notes, or if you've got electronic notes, what their escalation status is. And if you've got time, it can be really useful to look at recent blood tests and their meds chart. Have they got any recent PRN usage of pain relief or antiemetics? And then once we've got all of that information ready to go, and you'll already have a pretty good idea of what differentials you're thinking of, go and take a quick history from the patient. So for abdo pain, start with your simple stuff and do it well. So take a Socrates, and then go through associated symptoms. So if you get your chat box open again, can you have a think of what associated symptoms in abdominal pain would be really important to rule out? Brilliant, yeah. So nausea and vomiting, bowel obs, Yeah, vomiting blood, any blood in the stool, whether they pass melena, how they're feeling in themselves, feeling light or dizzy, that's good. And any signs of shock or abdo distension. Yeah, those are already good. So from the ones that we've said there, anyone with abdo pain, you should be asking nausea and vomiting, if they've got a fever, if they've opened their bowels, or if they do normally open their bowels. If they don't, do they have a stoma? What's in the stoma? Is it normal for them? Is it different? And what's their urine output like? Then moving on to your A&E examination, which we can go through with this case. So the information that you get from this patient, he's 59. He's 5 days after a hemicolectomy with anastomosis for cancer. So that means he's had a laparotomy, so a big cut down the abdomen. They've taken out cancer from the bowel, and then they've joined the two ends of the colon back together. So he doesn't have a stoma. He's complaining of worsening abdominal pain in the last 4 hours. He just says it's generalized everywhere. It's 10 out of 10. It doesn't radiate. Nothing's making it better. And moving is making it worse. He's unwell. He feels sweaty. He feels feverish. He's not been vomiting, but he's not passing much urine and he's not opening his bowels. When you go through your A to E, he's breathing fine, slightly tachypneic, but his stats are okay. And you can't hear anything on the chest. He's got a fast heart rate, a low blood pressure, a prolonged cap refill, and his mucous membranes are quite dry and he's got a fever. So already you can start thinking that this patient is not well. He is alert, however, but when you get to his abdomen, he's guarding. So he's tensing all his abdominal muscles and he's not letting you examine it, no matter how much you ask him to relax. You can't feel any masses through his abdominal muscles, but that's not a very reliable sign when someone's guarding. His wound from his laparotomy is dressed with a big dressing, but you can't see any strike through and there's no surrounding erythema sneaking out. So you think the wound's probably healing well. And then everything else, this is really important. So split it in your mind into something simple and easy to remember. What's going in, what's coming out. So is there anything going into the patient that you need to assess? So any cannulas, central lines, any PICC lines, any NG tubes. If there are any central lines, what's going in? Has he got a big bag of TPN running, or is it fluids that's going in? And what's coming out and from where? So just go through everything. Is there a catheter in? Is there a drain coming out of his abdomen? And if so, what's coming out of it? What color is it? How much of it is there? And is there a chart that you can look at to see what the trend of that has been? Has he got a stoma, or has he got any other tubes coming out, like a Riles tube, so a thicker NG, wide bore that's draining other stomach contents? So his news is a 9, so you can already tell that he's quite unwell. So breaking down your differentials for abdo pain can be quite daunting because there's obviously so many different causes of abdo pain. There's medical causes, there's surgical causes. Obviously for this lecture, we're focusing more on the surgical causes, but I'll just go through sort of different systems that some people might find useful. So the first thing to think of is where's the pain on the exam, and what have you got from the history? Do you think it's related to what brought them into hospital, or do you think this could be something new and something different? If you're at a complete loss, you could go through a surgical sieve, which I've got a slide on later. So everyone has different mnemonics, but I use vitamin C, E, D, F, which we'll go through in a sec. What system do you think this is related to? Do you think that this could be a post-op complication? So the common post-op complications are listed here. We will go through each one of these in a bit of brief detail, but we've obviously got quite a lot to get through, so it will be a brief run through. And then just little things to think about at the end. Is the wound infected? Is there a collection near it? Could that be causing pain? And as we already mentioned, stoma drips and other bits. So one of the ways to think through abdo pain is where. This is probably more relevant to clerking in ED or seeing people with new abdo pain that isn't already known or isn't after a surgery. So generally at the F1 level, you'll tend to be responding to ward bleeps on surgery jobs. So you'll probably be seeing patients that are either waiting for surgery or they've had surgery. As an F2, I'm currently on the core surgical trainee rota. So when I'm on call, I have an F1 with me who covers the wards, and then I cover A&E and I clerk in new patients. So for me, this is more useful. New abdo pain, where is it? And then simple things. What age is the patient? Are they male and female? I.e., which bits could have been affected and do I need to think of? So I won't go through all of this picture. You've probably all been doing a recent OSCE revision, so you could probably rattle off causes for different sections of the abdo. So this is the surgical sieve. This can be quite helpful, especially if you're at a loss for what you think is causing it, if you can't really pin down what's going on. The main things in surgery to cause abdo pain will either be vascular, infection, or trauma. So if you just pick every organ that you can think of in the abdomen or near the abdomen and think of what goes wrong if it doesn't get enough blood or bleeds, what goes wrong if it gets infected, or what goes wrong if there's trauma, either local or massive. So local trauma could be, for example, a kidney stone causing trauma as it gets pushed down a ureter, or big trauma could be, a stab wound, but obviously that'd be quite obvious. So going through the other ones, less common reasons would be, are you missing something medical? Is this patient a type 1 diabetic in DKA and presenting with abdo pain? Is this something that is quite benign and normal for the patient, like IBS or constipation? Or is something more serious going on, like an underlying cancer that's causing obstruction? And then less common things such as congenital, which would only really be for peds. Degenerative, thinking about other things, so the spine, the lungs, the testes, things that aren't necessarily in the abdomen but can still cause abdominal pain, and endocrine causes. So I thought it'd be useful just to go through the post-op problems, because that's probably something that you won't be particularly confident with. And when you get into a surgery job, you will just see these time and time again, and you'll get a bit quicker at recognizing the pattern and recognizing what you think is going on. So firstly, expected abdo pain. I don't know if anyone's been to see a laparotomy or abdo surgery, or been to see someone get their appendix removed. It is quite brutal. They get a large incision, bowel is manually handled, moved around, cut, burnt, sewn back together, and then it's washed out, which literally is just water into the abdominal cavity, and then it looks like they just play the drums in the abdomen and wash out all the blood and muck. So they're gonna have pain. It's usually within the first few days that it's worse, so you'll probably get bleeped sooner rather than later after someone's operation. I.e., if someone's pain is coming on day 6 after that operation and it's getting worse, you should be more worried than day 1. The abdomen's normally soft, so there's no other signs going on. They may appear quite well and may have normal news, although just be careful about tachycardia due to pain. Anastomotic leak is another common one. So back to our example, there's a chap who's had bits of his colon joined back together. Contents can leak out, and that can collect in the abdominal cavity and become infected. And that can make patients quite unwell. So they'll often present with fever, signs of sepsis or shock. When you try and examine their abdomen, it's peritonitic, and they may have little or no bowel output on their charts because their abdomen is, their bowels are basically in shock and they're not moving, so they're in ileus. Bowel perforation tends to be quite sudden onset, really severe pain, and this will be a patient who does not move. They cannot bear any movement. So when you compare this to, say, the pain of a kidney stone, which is also severe 10 out of 10 abdo pain, a kidney stone patient will be lying in the bed, writhing in pain. They can't keep still. They're really, really uncomfortable. Whereas a bowel perforation patient will just be lying still, trying not to move a muscle. And they can often present septic with peritonism. Collections and wound infections generally tend to have localized pain. If it's become more systemic, they may have fevers. And if there is a palpable collection of pus, you may be able to elicit that on your exam of the patient. And then another slightly less worrying cause could be constipation post-op. We give people a lot of morphine and painkillers. People aren't eating as well after operations. And some patients might not be eating at all, so they might be on total parenteral nutrition. So their bowel output is going to be really minimal. So that's something to consider when you're thinking about their bowel chart. More worrying would be obstruction. So common things to look out for would be colicky pain, because the part of the bowel that's trying to move things past the obstruction is working overtime. Absolute constipation. So someone who's not opened their bowels at all for 4 days and is also not passing flatus is a lot more worrying than, a 90-year-old who hasn't opened their bowels in a few days, but it's normal for them to go a few days without opening their bowels. Abdo distension and vomiting, which if it's a small bowel obstruction that's been going on for a while, it could be feculent vomit. And then the last common post-op differential would be bleeding. So are they showing signs of tachycardia, low blood pressure, shock? And we'll go through the sort of basic management of these in a second as well. And if there is any questions, just pop them in the chat and we'll run through them at the end of each scenario. So investigations, I think you've probably all heard of different frameworks, but it's really useful to go through bedside, bloods, imaging and special tests for anything, just so you don't miss anything. It will obviously depend on what you think the differential diagnosis is as to what you do. But anyone that's really unwell, especially if they've got a compensating tachycardia, you'd probably want to get an ECG done. If there's any worry about a urine infection, you'd want a dip and an MCS. If they're older, generally we tend not to dip the urine because it's not very reliable. And while you're at their bedside, obviously parts of your exam, their stoma and drain output, can you look at any fluid charts there? Blood tests. If you're worried about bleeding, you obviously want an up-to-date HB. If you're really worried about bleeding, you want an up-to-date HB now, so you want to get a probably VBG. And then UA needs to look at dehydration if someone's not eating very much because of their abdo pain. And if you're worried about infection, you want a full set of bloods with a CRP. In terms of imaging, simple tests that you can think about ordering would be, obviously we'll go through when to discuss with a senior and the practicalities of these, but abdo x-rays are good for obstruction. Erect chest x-rays are good for perforation to see if there's any air under the diaphragm. And an ultrasound is good to assess a localized collection. How big is it? Is it big enough to drain? Does it look like it connects with anything? Do we need to image it further with a CT? If you've seen a patient and you're worried, and you've just started a surgery job, you're worried about them, and you think that they may need a CT, if you're having any of those thoughts, you should be on the phone to your reg, because at the end of the day, they're the specialist in the area. And they should be coming to review that patient as well, or at least giving you advice over the phone as to what investigation that you should order. So coming back to those common problems first, expected pain, if you've ruled out worrying causes, just go through your analgesia ladder, check what they're on at the moment, what their PRNs are, and just go the next step up. If you're in hours, most hospitals will have an acute pain team, usually nursing led, and they can be really, really helpful to come and review the patient. And if it's out of hours, obviously you've got your own registrar, but it might be more useful going through, say, anaesthetics or critical care outreach. Anastomotic leak. So obviously this patient is at high risk of deteriorating, or they're already deteriorating in front of your eyes. So if in doubt, make the patient nil by mouth in case they're going for theatre. If you're worried about an infection inside the abdomen, start broad spectrum antibiotics like you would for any sepsis. That will differ by trust, but common ones for inside abdomen infections is AMG, so amox, metronidazole, and gentamicin. Do they need IV fluids? And do they need that as a bolus or maintenance or both? Do you want to monitor their fluid output? Do you want a catheter? Discuss with your reg, because they're probably going to need either a drainage. So leaks can sometimes just have a further drain put in to try and drain the fluid coming out of that leak if the patient's well, or if they're not well, they'll need to go back to theatre to have the leak sorted out. And the management for bowel perforation and a wound collection is fairly similar to above. So if in doubt, you'd want to make them nil by mouth in case they need theatre. Almost all cases of a bowel perf will go for a laparotomy. And most collections or wound infections will be managed with antibiotics and percutaneous drainage. So usually ultrasound guided drainage, just to drain that collection away if possible. And then they'll move to theatre later if they need. For constipation, just think about what laxatives are they on? Are they even taking them? Can you add anything else? If they're so constipated that they're not really opening their bowels, do you need to do a PR to see if they're impacted? And if they are impacted, then it's probably sensible to start with either a suppository or an enema, because if you think you've got a big blockage in the rectum that's stopping other stool passing through, you need to try and get the body to clear that. If it's got to the point that they've got overflow diarrhea, i.e. loose stool is pouring around this blockage to get out, then I'd probably get your reg to have a look at them as well. And we give people lots of medicines that constipate them. So can you look at their analgesia and see if there's anything that you can change to avoid constipation? And we've got more talks coming on analgesia, so stay tuned for that. Another worrying one, obstruction. So similarly, if in doubt, nil by mouth. And then the management at our level is get a Riles tube in and make sure you've attached the bag before you put it in. Otherwise, if someone is obstructed well, you will spray hose bowel contents everywhere and drip, so IVI. Make sure they've got a catheter. If they are still vomiting, make sure they've had some antiemetics on board to try and get that under control. And obstruction would usually go for surgical management, depending on the age and comorbidities. And then bleeding sounds simple, but if someone is bleeding from their wound and it's fresh red blood spurting or at least pouring out, someone needs to be standing next to that patient, just applying pinpoint pressure over that bleeding point while everything else is going on. They just need to be stood there holding it, because first aid is the first thing that's going to help that patient. If they're shocked, you could give IV fluids. If they're low in HB on the gas, replace like for like. So give some HB, give red cells, and get your senior involved. So just to recap, bring it back to that scenario, because I know we've sort of diverted and gone through the differentials for all abdo pain. So this is a 59-year-old chap. He's 5 days post-op. He's had a left hemicolectomy and they've anastomosed him, so they've joined it back together. He's got worsening abdo pain over the last 4 hours and he's septic and he's got peritonitic abdomen. So just the chat box again, if you can. What would be your top 2 differentials for this patient? So I can see there, yeah, we've got one. So anastomotic leak or perforation, brilliant. So those would be our top differentials. So again, in the chat, there's obviously a lot of things that we're going to do for this patient in terms of investigation and management. But between you, I'm sure we've got enough of you to try and name most of them. So if you go in the chat as quick as you can, what investigations and management would you like to do for this patient in the chat? And then we'll go through it on the next slide. Yeah, Abdo CT is what they will need. A VBG for lactate, nil by mouth, antibiotics, call your senior, ABG, bloods. Yep, brilliant. So you've obviously got a septic patient. So if you do nothing else, think of your sepsis 6 and go through and at least try and tick them off while your reg is coming. You'll need to keep them nil by mouth, which sounds simple, but just take food and drink off their table, because it can be really frustrating especially if someone's unwell and delirious, if they're reaching for their water bottle or something to try and start drinking, and you think this patient is unwell and is going to go to theatre. If they're in this chap, he's got a low BP and he's tachycardic. So he's starting to not compensate managing his blood pressure with his tachycardia. So you want to give him a 500 ml bolus of IVs. In surgery, if in doubt, I always just go for Hartmann's and then recheck the BP in 15 minutes. If he's not got a catheter already, you want a catheter in, broad spectrum antibiotics, blood cultures, which you need to take before you give the antibiotics. You'd want a VBG to get a lactate, because that will really help the surgeons decide how urgent this is. And think ahead, he's going to go to theatre most likely. So you need to make sure there's an up-to-date group and save. If you're in doubt, you can phone blood bank usually, and they'll tell you whether they need another one, a clotting, and make sure he's had an ECG done. If you're in any doubt and your senior's taking a while to come or not responding, or you feel like you're not entirely sure, then you could get an erect chest x-ray to see if there is pneumoperitoneum. However, in reality, for this patient, so if it was me, I would turn up, take my quick history and exam, do my A to E, and think, oh God, like I need my reg. Like there's lots of things that I can do right there and then for that patient, but the thing that is going to help them the most is early surgical intervention. So I'd probably at least have taken some bloods and a VBG while I'm there, made sure he's got some fluids up as a bolus, and sent off blood cultures and have prescribed some antibiotics that they can at least start running. But once I've done my basic things, I'm going to be on the phone to the reg, give a good handover, and just confirm that they're happy for a CT. And then hopefully the registrar will be able to help sort out the logistics for theatre. So consenting the patient, booking them, and fasting them. Other things that your senior can be really helpful is if the escalation status isn't clear and you've, say, got an 80-year-old with lots of comorbidities, do you need to revisit the escalation status? Do you think they're going to deteriorate in the night? And do you think resuscitation is appropriate for them? And if you're really worried and it is perhaps in someone that you think could die from this, do you need to phone the family? Do you need to get them in to see the patient if you think that they're not going to survive theatre? So I think that brings us to the end of the first case. If anyone's got any questions, feel free to pop them in the chat now, but we can always answer more questions at the end. But I thought it might just be easier to do case by case.
I think you answered questions brilliantly as you went along, Ben. There was just one, which is we can answer as we go along, if that's helpful, which is when doing an A to E, is it okay to ask nurses to help you to work through it and take obs?
Absolutely. If there is an unwell patient and you're doing an A to E and they're acutely unwell, I'd want the nurse there with me. Usually I'd have more than the nurse, usually a HCA and a nurse, because if you're there and you're thinking, I need a lactate, you're not going to want to go leave the patient if they're critically unwell to go get equipment. So, and it's really useful to have a runner. You know, other people can request imaging. If you think, oh, I need a chest x-ray now, you could ask politely if someone could go and request that while you do the bloods. So yeah, and the nurse can be taking up-to-date obs. They can be getting the fluids ready. Sometimes they can even help if you've got CSWs on, clinical support workers. They are lifesavers. So I've done A to E's before and got to the end. Clinical support have arrived and I've asked for a gas, blood culture, and they've done all of that for me. So yeah, definitely the more hands you can get there, the better.
Fantastic. And one more question on this scenario before we move on is, what would the lactate tell you about severity?
So the lactate tells you how well organs in the body are being perfused, to speak very simply from a surgical point of view. So if you've got someone that you were phoning your reg about and you said, I'm worried that this person has perforated and I think they need to go to theatre, and your reg says, what's the lactate? And you say 0.5, they're probably going to say, are we sure the diagnosis is right? Whereas if you phone and say, with this chap, I've got a 59-year-old, he's 4 days post-op, he's septic, and the lactate is 5, they're going to take you a lot more seriously and come and see that patient quicker, because it shows that the organs aren't getting the blood that they need because of the sepsis and the low blood pressure. Anything else on Abdo?
Brilliant.
Cool. So what time are we on? 35. That is the biggest topic, to be fair. Abdo pain is quite a big one to cover. So next is doctor, this patient won't stop being sick. So we've got a 35-year-old female and she's complaining of nausea and vomiting and she won't stop being sick. You've got the nurses on the phone. So I won't labour it because we went through it last time, but ask for an S-bar, what they came in with, who's calling, where from, are they unwell, what's their news score, red flags for the symptom that they're phoning about so that you can prioritise. So for nausea and vomiting, that would be, is there blood in the vomit? Are they choking on their vomit? Or are there any other signs and symptoms that you're worried about now? Before I arrive, please can you? So you've asked all the important questions and you're on your way. So my walk thoughts for a vomiting patient would be, how long have they been vomiting for? Am I worried about them aspirating on their vomit? So I need to remember to listen to their chest, and I might need to get a chest x-ray. And then what are the worrying causes of vomiting? Are they obstructed? How's their abdomen? How bad is this? So we get there, eyeball the patient, and they look okay. So you go to the notes and you look through what's brought them into hospital, what they've had so far, and what their escalation status is. You look through their recent bloods and you look through what current meds they're on. And for this, you'd want to check if they're on any antiemetics. And then you go to the patient and get a history. So what are the most important things that I want to find out about vomiting? And what are the associated symptoms with vomiting? I've already mentioned a couple that would make you worried in the chat. Oh, I've revealed them. Hopefully you weren't quick enough to see that. I promise there's not more interactive slides. I think this is the end. Coffee ground vomit, yeah. Bile and blood, yeah. What is coming out of their mouth? If there is blood, how much of there is it? That's good. How much, how often, color blood, poo, yeah. The taste of the vomit, ooh, I like that. And the volume, good. So, vomiting. Just think simply. You want to know how long for, how much they're bringing up, what the color of it is, and therefore what do you think it is? Is it bile, food, stomach contents? Is it blood? Is it poo? That is the starting point for all your differential diagnoses. And then while they're vomiting, is there anything else happening? Are they in pain? Have they got a fever? Are you worried about an infection? And what's happening with their bowels, their stoma, or their urine? So for this patient, you take her history and you examine her. She's 35. She's day 1 after having her appendix out. There were no complications in the surgery. She's been vomiting all through the day since her operation, but it's just stomach contents and there's no blood. Her bowels are opening fine. She's afebrile. She's passing urine, but she's noticed that it's a lot darker than usual and it's stinging. When you examine her, airway and breathing are fine. She's ever so slightly tachycardic, and her blood pressure for her seems to be normal, but slightly on the low side. But she's got dry mucous membranes when you look in her mouth, and her CRT is 3. D is fine, and E is fine, and she's using a 1. So differentials for vomiting. Lots of different causes of vomiting. Again, there's abdo pain, but try and break it down into something that makes sense to you. So are they vomiting from pain, i.e., can I treat the pain and make the vomiting better that way? Or do I need to give them an antiemetic as well? Is it something worrying, like an ileus? So ileus is when the bowel is not moving and peristalsing as well, and so their bowels will not be opening. Or are they obstructed, i.e., are they in pain, this colicky pain, with bowels not opening, vomiting, distension, the works? We've done that. Is it to be expected? Are they after an operation? Is it post-operative nausea and vomiting, which we'll talk a bit more in detail about later? Have they just had a general anesthetic? That can also make it worse. Is this a symptom of something else, like an infection that I need to treat? Or are they on any medications that could cause vomiting? Essentially, do I need to be worried? When you're trying to prioritize vomiting, it'd be quite difficult because vomiting can be really serious. But usually the nurses are pretty good at telling you whether they want you there right now, i.e. they're vomiting large amounts of bright, fresh red blood, or they're fine, i.e. this 35-year-old day 1 post-op, I probably wouldn't go and see straight away. I'd probably check that she's got some antiemetics prescribed, and I'd see if anyone's dipped or sent her urine because she said she had stinging urine, and that would help me decide where I see her in my list of patients. But if you compare her to the chap before, she's obviously lower down on the priority list. So differentials, we'll just go through a few of them. So post-operative nausea and vomiting is very common. It usually occurs about a day or 2 after an operation, and it can actually affect about 20 to 30% of people. And we'll go through the risks of it and what can happen later. Infection, don't need to label that. Have they got fever? Is there a localizing source on the symptoms, signs, or examination? An ileus, like we said, the slowing or halt of intestinal motility. So it's kind of like a functional obstruction, i.e. there's nothing actually blocking the bowels, but the bowels aren't working. It's an examination finding that's often thrown around, but absent versus tinkling bound sounds is the sort of classic way to determine between ileus and obstruction. But in reality, they're both, they can be quite difficult to tell the difference between, but for either of those patients, you'd be getting your registrar involved anyway. So it's just about getting exposure to them and learning as you go. Obstruction, we've talked through already. Medication, common causes include opiates and antibiotics. We start a lot of people on metronidazole. If I think about everyone that I admit through ED, I can probably say for those coming in under general surgery, so think appendix, gallbladder, diverticulitis, obstruction, things like that, most of them will get started on AMG, amox, metronidazole, and gentamicin. So we love metronidazole, but the patients don't. And then a couple of other things. Go back to your surgical sieve. Are you missing something? Have they got raised intracranial pressure? Are they just anxious? Is this normal for them? So bedside investigations for vomiting. If they were tachycardic or you were worried about chest pain with vomiting, then make sure you get an ECG. If there are any symptoms of a UTI, if they're young, dip, and that can help you decide treatment, or if they're, and send an MCS. And if they're old, just send an MCS. And then drain and stoma output as well while you're there. Bloods we've gone through, so infection, white cell CRP. Are you worried about the patient? VBG. Are you worried about dehydration? UNEs. In surgery, you can tend to get away with a VBG as your gas of choice. ABGs, so arterial blood gas, tend to be much more important if you're worried about the oxygenation of a patient, or if they've got COPD and we're starting them on oxygen and we're worried about them retaining. So generally for surgery, we're interested in the HB, the UNEs, and the lactate, all of which you can get on a VBG, venous blood gas. So that's usually good. And it's good for us because I don't like doing ABGs unless I absolutely have to. And then UNEs for dehydration. Similar investigations as before, and CT would be chat to your reg. So management for vomiting, just start with simple, easy things first, and then work your way down towards the more fun stuff. So are they dehydrated? Do they need fluids? Are they obstructed? Do they need a Riles tube? To help avoid them aspirating that vomit, a Riles tube can decompress the stomach. And actually the patient will thank you for it because they're feeling so nauseous from their obstruction because they've got everything that's trying to go one way coming back the other way. And you put in a nice big tube that just brings it all out, and they usually start to feel better quite quickly. A note about CTs. If you are querying obstruction and you're sending a patient for a CT, it's really good practice that they have a Riles tube in before they go. Because if you think about how a CT works, you're just lying this patient flat who's vomiting, and you're just asking for trouble and aspiration if you haven't decompressed their stomach, or at least started that process before they go. And then getting down to the active treatment. So antiemetics, which is useful to know what you're treating before you treat, i.e. what is the cause of this vomiting. Analgesia to control the pain, laxatives to treat constipation if that's what you think the cause is, or antibiotics. Can you switch the antibiotics to something that you think won't cause the vomiting if you've excluded all the other sources? Or do you need to start antibiotics for an infection that you think might be causing the vomiting? So lots of things to think about. So just to bring it back to this lady. So she's 35, she's day one post-op. She's got a slight sinus tachycardia on the ECG that you've done, and she's got dry mucous membranes. She's peeing, but it looks quite concentrated and it's stinging. So you do an ECG, you send an FBC and UNEs, you send a urine dip, which shows leukocytes and nitrates when the nurses come back to you with the little piece of paper with all the pluses on it, and you send it to the lab. And actually, I've forgotten CRP on that, CRP. So the top differentials for her, she's got a likely UTI. So she's young, she's got symptoms, and she's got a positive dip. So for most hospital guidelines, that would be enough for you to start empirical antibiotics, i.e. cover all infections that would commonly cause a UTI, and send it to the lab. And then if the lab comes back with a different bug that doesn't cover, you can change it later. If her dip was negative and she was complaining of stinging urine, I probably wouldn't start her on antibiotics, because it's quite common for concentrated urine to sting slightly as it passes, because the concentration of urine things are higher. Obviously, if she deteriorated or she had a fever, or there were other signs at the same time, then you could start, but that's just a side note. That's a whole lecture in itself, probably. She's day 1 post-op, so post-operative nausea and vomiting, and she's dehydrated. So to manage her, we want to correct all of those things if we can. So correct the dehydration, give her some fluids. Correct the pain from her stinging when she passes urine, give her pain relief. Try and bring that nausea and vomiting under control. Antiemetics, good ones would be ondansetron or cyclizine. Treat the cause of what you think is causing it, so antibiotics. And see if she's already on analgesia, and if she's using her PRN doses, and go through the pain ladder as you need to. For her, from that history, I probably wouldn't be doing an NG tube at the moment, but it's something that you can keep up your sleeve for later if things worsened. So briefly, 20–30% of patients after a big surgery will complain of nausea and vomiting. We've talked about the risk of pneumonia, but there's also risks of metabolic alkalosis and surgical complications, because they're increasing their intra-abdominal pressure through the act of vomiting. So that could make it more likely for them to burst their sutures and start bleeding. It's more likely in young females. It's more likely in those who haven't got adequate analgesia on board, more likely in longer operations, longer anesthetics, and more opiates. So the management for it starts before they've even gone to theatre. So try and plan to reduce the amount of opiates that they have. You can give them prophylactic antiemetics before they even start experiencing this. So for all surgical patients, you should make sure that they've got PRNs on their meds chart ready to go, and the nurses can give that before they start experiencing nausea after an operation if they'd like. And there's some evidence that dexamethasone before an operation can help reduce this as well. And then we've gone through conservative sort of non-pharmaceutical measurements would be rehydrate, pain relief, decompression, and then the pharmaceutical side of the vomiting would be either sometimes ondansetron and cyclizine are much better at targeting opioid-induced nausea, whereas metoclopramide is better if you think that the bowel isn't moving as well as it could do, which is causing a build-up and therefore nausea. But a note, do not prescribe that in obstruction, because you will make their pain worse. Because if you think about it, you've got something blocking the bowel trying to push against it. And then if you give them a prokinetic, you're basically making everything worse. So that was a brief tour of vomiting. Does anyone have any questions from that case before we move on to urine output?
So there were a couple which I've kind of answered as we've gone along, mostly about blood gases, which we can clarify, just to mention, because it might be useful to everybody, that you can get an initial HB back on your blood gas as well as sending one to the lab, and also you can get a lactate on your VBG as well as your ABG, and so that's useful. But just quickly, there were a couple of questions mainly about chest x-rays, which have been ongoing, which would be useful more on the pain and vomiting. So one was, can you use a chest x-ray? How do you use a chest x-ray to assess aspiration?
So sometimes if someone's aspirated a massive amount of vomit, that vomit's obviously gone down their trachea into their lungs and it's in the wrong place. So if you get a chest x-ray, you can compare it to previous ones, or sometimes you won't even need to, and you can see that there's consolidation in the lung that wasn't there before. And so you'd be worried about whether that was vomit. In those patients, you'd be starting antibiotics to cover for a chest infection. It can be quite difficult if they've started vomiting and the nurses give you a sort of vague history of, oh, they were vomiting and then they started coughing afterwards, so I think they've aspirated. That kind of then leaves you with a bit of a grey area if you can't really work out whether they have done. And small aspirations might not show up on a chest x-ray straight away. So as long as you cover yourself and document that, you know, they've not dropped their SATs since the vomit, the patient's not complained of any obvious shortness of breath or cough, And if you think that a chest x-ray is needed, you've done a chest x-ray and it's clear, then you'd be fine to sort of rule that out for the moment, but bear it in mind for later if they were to deteriorate.
Fantastic. Thank you for that, Ben. That's very clear.
All right.
There's a couple more questions about antiemetics, but I was just going to say that we're also having a prescribing lecture specifically on antiemetics, laxatives, analgesia, a bit about fluids in our 3rd week, so on the 8th of June. So I'm going to leave those questions for now unless we've got time at the end, and I'll let Ben continue because we'll be discussing antiemetics and all the different types and how they act in a lot more detail later. So continuing on, Ben, thanks very much.
Brilliant. So we've got the last 10 minutes just to go through urine output and then any final questions at the end. So this patient isn't passing urine. So you get bleeped. It's, what time should we make it? It's 4 a.m. You've just tried to go to sleep and your bleep's gone off, and the nurses are bleeping you that a 75-year-old man has got a low urine output on his fluid chart. They love sitting at the desk and doing fluid charts at 4 a.m. So 4 a.m. is a good time to get bleeps about this. Questions for the nurse, red flags. Are they in pain? Does their tummy look distended? Have they got a catheter in? Is it draining at all? I.e., is it low urine output or is it no urine output? What's their news score? Do they look unwell? Do you think this could be an infection? Things to do before you get there, we'll come on to. Mainly catheter things. If you thought it was blocked, there's quite a few things that you can ask the nurses to do before you arrive. Sometimes you can even ask the nurses to do and not arrive, and it usually sorts itself out, but we'll get to that. So you've asked the important questions to prioritize this patient in your list of things. The walk thoughts, any recent surgery, have they got a catheter? Make sure you keep in your mind that you've got to look at that fluid chart. For some hospitals, that will be electronic, which is great for you. For some hospitals like Harrogate, it will be on a piece of paper at either the nurse's desk or a folder somewhere, or the patient's bedside, or the floor, or the doctor's office. So you have to find it, or it might not exist. Have they got fluids running already? What's their recent kidney function showing? Is this serious? And then just to think in your mind, how heavy is this patient and how much would I expect their urine output to be? So anything less than 0.3 mils per hour per kilogram would be worrying. So you get to the ward, you eyeball this 75-year-old man and he's sat up in bed. You go and say hi, that you're the doctor and you'll come back soon. And he says, that's fine. And you think that you've got time to go to the notes. So you go and essentially you're just prepping like almost like a tiny little ward round mini review. So their age, what they came in with, what treatment they've had, what surgery they've had. Any catheter documentation that might be in the nurse's documentation or on their handover. So getting a verbal handover from the nurse is really helpful. I.e., what catheter have they got in? Is it a long-term catheter? Is this something that they always have in? Or is this a short-term catheter? Is this something that's only been put in for surgery? And then the dreaded fluid chart. Recent bloods, recent meds. So history for urine output, you want to think, what are the really worrying causes of a reduced urine output and what would those symptoms be? So fever, are they septic? Is there an infection that's causing low blood pressure, low kidney perfusion, and so reduced urine output? Is there a specific sign or symptom such as loin to groin pain that might suggest something else like a kidney stone? And then I like to break everything down really simply so that when you're stressed, you can remember. So what's going in, what's going out? So in, is the patient drinking? Are they allowed to drink? Are they nil by mouth? Have they got fluids running? Have they had the correct maintenance fluids for the last couple of days? Or have we just let this patient turn into a crisp? What's coming out? Have they got any symptoms? Is it easy for them to wee? Does it burn? Does it sting? How much is coming out? Is there blood in it? Is there pus in it? Where is it coming out from? Have they got a catheter or have they got a urostomy, a tube, into the kidney, or have they got a suprapubic catheter, a catheter coming out of their bladder? What's normal for the patient? So you go through all of those things for this man. He's 72. He's his second day after having a right hip hemiarthroplasty, and he's had some blood loss in the operation, which you've noted on the op note. He's got hypertension and he's on ramipril. He's been nauseous since his operation, but he's not been vomiting. But you notice from the fluid chart, which you think looks fairly accurate and sounds accurate from the patient, he's only drunk 400 mils in the last 24 hours, and he's weed 700 mils. He is catheterized, but it was only done for the operation. There's no blood in the catheter bag. His bowels are opening. He feels fine. He's not in pain, and he's not got a fever. You examine him. Airway and breathing are fine. He's slightly hypotensive. He's dry. And there's no signs on examination. And the catheter's draining really dark, concentrated looking urine. Not for him, but in anyone with reduced urine output, if they're not opening their bowels, you really, really have to do a DRE or PR just to make sure that there's not impaction. So lots of hard stool in the rectum, because if there is, that can cause acute urinary retention, and they'll need a catheter and they'll need lots of enemas, which the nurses will love you for. So differentials for urine output, I like to think of it as before the kidney problem, or after the kidney problem, kind of like how you'd go through AKI. So pre-renal problems, have they lost volume? Have they got a low blood pressure, or is something wrong with the artery supplying the kidney? In renal problems, so is there any drugs that are causing problems for this kidney, or is there any kidney disease going on that's known or new? And post-renal problems, which is the most common in surgery. So is there something wrong with the urethra? So is there a stone in there? Is there a tumor? Is there something wrong with the bladder? Are they in retention, or is their catheter blocked? Or is there something wrong with their urethra? Is there a UTI causing irritation so they're not weeing? Or have they got a massive prostate? Or have they got, problems with strictures or fibrosis from previous urology surgeries and stuff? So the common ones that you'll see: acute urinary retention. In some patients, it might be chronic. So they might have known prostate problems and say, I always have problems weeing, it always dribbles. I can never get enough out. I always feel like I need a wee in the middle of the night. Those sort of problems. In hospital, constipation is really, really common for reasons that we've already gone through. And less common causes would be a prolapse, so like a rectocele or kidney stones. And then just things to think through. If in doubt, just think, what's common? What do I really need to be ruling out? And that's infection, low blood pressure because of either low input or sepsis, drugs that the kidneys don't like, stones that the kidneys don't like, urinary retention, a blocked catheter, or an infection. And then we won't go through those at the bottom. Just if they are hypotensive, so they've got a low blood pressure and a low urine output, just think through what's causing this low blood pressure. Is there anything that I can treat, or is there anything that I need to investigate? Speaking of, so DIPS and MSU, if you're worried about retention, ask for a post-void bladder scan. So the nurses will be really good at getting this done. Essentially, the patient will try to pass urine. So if they can't, that's fine. If they can, a dribble comes out or whatever, and then they get a bladder scan. And different hospitals will have cutoffs for what they would call retention and needs a catheter. Commonly, it's about 600 or 800 mils. Is there anything going on with their OBS that you need to investigate with an ECG? If you're worried about infection or dehydration, send some blood tests. If there's constipation or impaction that's not resolving, do you need to be thinking, is there really severe impaction going on that might need treatment from the top and the bottom? So normally, if there's just a small amount of impacted stool in the rectum, you can get away with an enema and regular laxatives like Movicol. But if you do an Abdo X-ray for someone that's really struggling, and you just see stool over the whole of the abdomen, you're going to need to go with one of my Jerry's consultant called the Movicol bombs, which I absolutely loved, is 8 Movicol sachets once a day until their bowels are opening with enemas. So you're basically hitting this really impacted stool from both ends to try and get the bowel to clear it out. And if you're worried about urology issues, so any problems with stones, or they've got fancy urostomies, or they've only got one kidney, or you think they've got a kidney infection, but you're not quite sure what's going on, they may need an ultrasound of their kidney, ureters, bladder, or they may even need a CT. So the initial management, obviously for hypovolemia or hypotension, think about sepsis and manage it as we've talked about before. If they're an AKI and they're on nephrotoxics, you need to make sure those are withheld. If you think they've got a kidney stone, so the common presenting complaint is severe loin to groin pain, and this is the patient that's writhing in pain, they can't keep comfortable. They commonly have blood on a dip as well, and that's from the trauma to the ureters. You need to make sure they have got adequate analgesia, and these patients will need a lot of pain relief. They're often the ones that just cannot get comfortable in the ED. So commonly that would be diclofenac, PR, antiemetic, and they will generally need a CT. There's some sort of debate about which is the first investigation that you should get for suspected kidney stones, but generally get urology involved early on, and they'll probably want a CT KUB. For acute urinary retention, you may be able to feel their bladder. My friend was working in the combined assessment team, sort of less urgent than A&E, basically clinic, and had a patient come in with 2 litres in his bladder and said that he palpated his bladder almost up to his xiphisternum. So essentially this patient was almost pregnant with a bladder. And yeah, just make sure you do a post-void bladder scan and then catheterize them, obviously try and get that urine out, and treat any causes of that retention. Blocked catheters are another really common call. Normally, the nurses have tried their best to get around it because it is a common thing for them to come across on the ward. Think about it in a patient who you think on exam should have a good urine output, i.e., they're drinking well, they look well hydrated, and you're just a bit confused why they're not passing urine. You can try flushing it with just water to try and see if there's any blockage in the actual catheter to flush out. If you do flush it and it does manage to start draining and there's quite a lot of debris, if they've had a really bad urine infection and there's lots of sediment or pus or blood, if they've come in with hematuria that's coming out, you may need to start some irrigation. So that's fluid going in through a 3-way catheter into the bladder and just keeping a steady stream of fluid running through so that any clots or bits of sediment can just pass out with that fluid running. And then just think of simple things. Is the urine bag below the bed? If the urine bag is sat next to the patient, gravity is not going to be working very well for you. So hook it on the bottom bar or put it on the floor, depending on what system they use. And another common one is if the bag is completely stuck together, an air block, then urine might not be able to get in. So just always making sure there's a bit of urine in the bag so that the bag is actually able to take more urine. And if you can't get anything and you're worried, you may just need to replace the catheter. And then the final one that we'll go through for the initial management, a bypassing catheter. So I'm weeing doctor. So a patient that says, I've got a catheter in, but I'm still weeing and it hurts. So that's, if this diagram down here, urine is coming between the balloon that you've inflated to keep the catheter in the bladder, and it's coming under that balloon and around your catheter tube through the urethra and out. So it's not going into the bag, it's going all over the patient and it's painful. This usually happens because of spasms in the bladder. So this tip could be irritating the bladder wall up here, which causes the bladder wall to contract and contract, which can force urine under that balloon. So things that you can try before contacting urology is sometimes deflating the balloon slightly. So usually 10 mils are put in, but with most catheters, you can get away with 5 mils. That might just help reduce some of the irritation. A smaller catheter can sometimes help. And if in doubt, refer to urology, and they may need to put a fancy catheter in, which essentially doesn't have this tip down here. It just has a balloon with a hole in the top, which can reduce irritation, or they might start antimuscarinics to try and help relax that bladder. So back to our final man. So he's 75. He's 2 days after his operation. He's hypertensive on lisinopril, but you have a look into it and that hasn't been held around his operation. So he's still been taking that. and you have a look back through his OBS chart and you can see that his blood pressure has been running really low since his operation. He's not drinking much. He looks slightly dehydrated. He's nauseous, but he's not vomiting. So differentials, clearly he's hypovolemic. So that's from two things. He's lost blood and he's not drinking much. And then you've sent off some bloods, but you can be pretty sure that he's going to have an AKI due to the above and because he's still on his ACE inhibitor. So for him, only really got to do some simple things because it's quite clear from the clinical history and exam what's going on. So you'd want to send some up-to-date bloods and get an ECG. Management for him, he's got a low blood pressure, so I'd probably give him a bolus, but I might be more gentle with him if he's 75. The only background we found out is hypertension, but commonly these people, elderly patients, can have problems with heart failure. So you want to be a bit careful with the amount of fluid that you give. So if they're very old, frail, or have heart problems, I'd probably go for 250 mils bolus and then prescribe him some maintenance fluids and recheck his OBS in 15 minutes. He's nauseous, so try and treat that with what we've gone through before. Withhold his ACE inhibitor. And when those bloods come back, if he's lost a lot of blood, you don't want to just be replacing that with fluids. You want to replace like for like. So give him some blood and make sure he's got some repeat bloods organized for the morning. So I think that's the end of urine output. Do you want to ask any questions for urine output now? And then I've just got a quick summary slide. Actually, I'll do the summary slide and then I'll just take all questions. So my take-home message for surgical on-calls would be the most helpful thing for you when you're on shift is to get really, really good handovers from the nurses, because that's going to make sure that you can prioritize these patients well. So take a good SBAR, ask for red flags, ask for simple things, and then please can you, what can this nurse do to help you before you get there? At our level, we're mostly on call going to be doing really quick investigative work, A to E's, and doing simple things well, like fluids, ECG, making sure they've got treatment for infections, and then escalating to our reg if we're not sure. Make sure you've got a differential at the end of your examination and history, even if you're not sure what's going on, because it just makes you think, and it makes your investigations and management a bit more thought through if you've had an idea of what you're treating. And then in terms of escalation, it's probably something that we might get some questions on later, but some hospitals do have a sort of new score cutoff that the registrars are meant to come and see that patient. So in some trusts, anyone using an 8 or above should be seen and reviewed by a middle grade. Not that always happens, but you've got a lot of people available in hours and some people available out of hours. You'll have your SHO. They might be busy clerking, but they'll usually be around to answer the phone or come and see a patient if you're worried. You've got your surgical reg and you've got the medical reg if you think that your surgical reg isn't going to be much help or they're not being much help. In hours, you tend to have the critical care outreach team, which is often nurse-led, but they can be really helpful to come and do an A to E. They can help with blood gases. They're a good point of call between you and ITU, and they'll often get the ITU reg to come and see the patient if they're worried. Some hospitals have the medical emergency team, and some hospitals only have the 2222 team. And don't forget, if you're struggling and you can't get hold of anyone, you have got the consultants on call as well. And then other things, just remember, you're only one person. You can have a few people on the phone shouting down at you that you've been 2 hours and you've not come to see this lady who's got abdo pain, but you are just one person trying to do all of this work. So just try and be self-aware. Do you need a 5-minute break for a cup of tea? Just might make you more productive. Respect the nurses because they can make your life so much easier if you get on with them and if you respect what they do, and they'll just work really well with you. And it sounds really cheesy, but just try and find the fun in shifts, because there's always something to smile about at work, or even days where you run off your feet and you just can't believe that you've got 5 people left to see and it's 1 hour till handover. Just the nurses know that you've got really hard jobs, and just have a bit of a laugh with them about how ridiculous it is that the staffing's so bad, or just try and take those little breaks, and yeah, you'll all be fine. So any any questions on the chat about anything at all, be it the urine output or anything, or surgery questions that you think I can help with that might not be coming up in lectures to come?
Yes, amazing. If you just go to your next slide, Ben, while everyone's still here, I'm just going to say this is our feedback slide. So firstly, we'll get on to questions, but just while everyone's still here, in case you don't want to listen to the questions, and thank you so much, Ben. Honestly, a fantastic lecture, really encompassed everything, and I think is really useful to probably for everybody. The lectures will be on our website, so you can go back over the slides. There's some really good detail there that would definitely have helped me out on my F1 surgical jobs. And just to say that you get a certificate as well if you feed out the feedback. Not only is it a massive help to Ben, but also it's really helpful for NSTS going through for making these lecture series in the future, looking at what you guys want and what you guys feel like you need. So while we're going through these questions, if you guys could use this beautiful QR code to fill out some feedback, that'd be much, much appreciated. And then I'll quickly ask some questions, Ben, if you're not too...
Of course, if I can.
No, absolutely. So there are a couple of ones that I thought might be a bit easier to discuss. One was from before that I missed just as I was going through, and it was about another question about chest x-rays, basically saying if gas is pumped into the peritoneum during surgery, wouldn't you expect to see some level of pneumoperitoneum on the erect chest x-ray in the short term? Don't know whether you...
Yeah, so simple answer, yes. If they've had a recent laparoscopic surgery, so if they've had their appendix out, and you know that they're day one post-op and they've literally just had gas pumped into their abdomen, then they will have it. But if they're in that chap that we had the scenario for, he was day 4 or 5 post-op, a laparotomy. So I'd be much more worried if I saw gas under the diaphragm in him, because by day 4, 1, he didn't have any gas pumped in because it was open surgery, and 2, any air left in the abdominal cavity by day 4 or 5, I would have expected that to be reabsorbed. But yeah, that is a good thing to think about and really good question. Yeah, if someone's just had laparoscopic surgery, don't do an erect chest x-ray because you're probably going to see gas.
Brill. A couple of other questions. So this one's talking about analgesia to give in kidney stone patients with a history of ischemic heart disease. So to be honest, I don't know whether this is referring, because I don't think you can always give diclofenac. Suppositories is normally your go-to.
Yeah.
Do you have any experience with kidney stone patients with ischemic heart disease?
Not that I've clerked in, so I've never had to Google it, but this is where Dr. Google would be very helpful.
Yeah,
but
look up and come back
yeah,
to you.
if you had any doubts with diclofenac, or patients had an intolerance to diclofenac and you couldn't give it, just stick with your usual analgesia pain ladder. They'll be on paracetamol. If they can have ibuprofen, they could have that instead, or other NSAIDs, and Oromorph. And if in doubt, the pain team would be really helpful because they're used to sort of more complex pain patients.
Absolutely, and there are lots of things that you can try. So PR diclofenac is kind of the go-to in kidney stones because it's really, really helpful. But someone's mentioned things like Buscopan can be really useful. It just depends on the patient and their pain, and that will also be covered in the prescribing lecture. We'll go through analgesia and the pain ladder and all of the different sort of options with managing surgical pain. Afterwards. Oh. Next question is about bypassing catheters and why you'd maybe use antimuscarinics.
So that would be, you guys should be able to answer that better than me with your recent med school days. But it's to do with the innervation of the bladder wall, and it just helps reduce the irritation of the bladder wall and helps reduce overactive bladder symptoms. So cramping of the bladder wall, which squeezes the urine out, is my very simple understanding of it. But I'm sure there's a better pathophysiological explanation out there.
Yeah, fab, that's good. Fabulous, we're getting there. Someone just mentioned why in the low urine output case you'd probably get an ECG. Is that due to electrolytes?
I think, let me go back, he might have just been tachycardic, or she.
Yeah. But yeah, always good to check with electrolytes as well, if potassium, if you're worried about it.
Urine output. His OBS, so I just move my questions out of the way. I was probably doing the ECG just for the low BP if it was new, but that was being very safe. You could probably get away with not doing an ECG for that chappie. But yeah, if in doubt, ECGs are just really useful to cover your back to make sure that you've not missed a cardiac cause for low blood pressure, or an odd rhythm for tachycardia.
Fabulous. Feel free to go back to the
Oh yeah.
lab, all of those people who are still here with us who are excitingly filling in their feedback. And the final question, I think you actually answered this as we went along, which was just about escalating, just to go through the different types of escalation calls, so like a MET call or a trauma call. But I think you actually spoke about those. You could just briefly re-summarize the final point.
So escalation calls, every hospital will have a different system, and that will usually be part of your induction as to how the different calls work. But generally, for surgery anyway, you can have different bleeps. So the trauma team is usually the orthopedics team, with the anesthetics ITU, and they'll be called to ED to see new trauma calls. So someone gets hit by a car and the ambulance are having to hold them in a C-spine brace. That's a trauma call. So usually it's the SHO that's on the trauma team, so you won't be on that as the F1, and you won't be putting those calls out on the ward unless you're in ED. So don't worry about trauma calls. MET calls is the medical emergency team. Some hospitals have this, and essentially it's kind of like a softer version of a crash call. So the patient's not, the patient's not dead. The patient is about to die, and that is the same team as the crash team, usually without the anaesthetist. And it's just really helpful if you need help now with a really unwell patient, but you don't think that you need the crash team because they've not arrested. And then the 4-2s is obviously anyone that has arrested, or in hospitals without an emergency team, that is also the emergency team. So if someone's, bleeding, they're bleeding a lot, they've got really low blood pressure, they've started to complain of chest pain, and you think, God, this person could really deteriorate or even die on me, and you've not even got time to phone your reg, then you just put the 2s out.
Amazing answer. Thank you, Ben. So that is the end of this lecture. Thank you all so much. Remember to fill out this feedback, especially if you'd like a certificate to show that you've been here and your attendance. Massively appreciate you, Ben, for doing this lecture and all of your help. If you guys have any further questions going on, feel free to get in touch with NSTS via our website or email, but stay tuned for the rest of the webinar series, so that every Tuesday and Thursday. The first week is now complete, but that'll be for the next 3 weeks. I know a lot of questions come up about prescribing, so that's why we're going to do a specific lecture, but the next 2 next week will encompass some more cases, more things you'll get bleeped from the ward along this theme, and anything else that you'd like to hear about during this lecture series, just get in touch or put it on your feedback. Thank you very much for joining, everybody, and hope you have a really good bank holiday weekend.